Right. Welcome everyone to the May meeting of the Oregon Health Policy Board. Give just a couple seconds for people to come into the room, virtually speaking. Thanks for being here today. We'll start with some housekeeping. Kirsten Isaacson, Vice Chair of the Oregon Health Policy Board. I will be chairing today's meeting. Our Chair, Oscar Arana, is unable to make today's meeting due to last minute conflict. But we'll be back with us next month in his trusty leadership and meeting chairing, and it'll be great. We look forward to having him back. So housekeeping for today's minutes, the Zoom chat feature in today's meeting only allows meeting attendees to message the host and co-host and no other meeting participants. Any questions, thoughts, and comments can be sent via Zoom chat to the meeting host, co-host, and then they do a great job at passing them to us so we can make sure that all comments are on the public record for all to hear. Now and in the future, because the recording is a video recording. So all materials for today's meeting are available on the Oregon Health Policy Board website and are hyperlinked in today's meeting agenda. Kick it off with a roll call from Tara.
Great, thanks, Vice Chair Kirsten. We know Oscar won't be with us today, so Kirsten Isaacson.
I am here.
Brenda Johnson.
I'm here.
Bill Kramer.
Here.
Melina Moran.
Here.
Sandy Sampson. Okay, do we have Jessica Gomez? All right, John Santa.
Here.
Okay, great. We have 5 members present and we have quorum, and I'll check on Sandy and Jessica.
Great. Thank you, Tara. Thanks everyone for being here. Happy to see your faces this spring morning. So a couple of updates and announcements. The Healthcare Market Oversight Program provided its monthly update in the meeting agenda as attachment number 1.1. There's not a presentation update today, but do take a moment to read the update and let staff or the chairs know if you have any questions. And related to that program, I did want to highlight that there's a report being released today. The 2022 annual cost growth trends report. So that report is going to cover growth trends from 2018 to 2020, state and market level. So this divides into Medicaid, Medicare, commercial levels relative to the cost growth target. The report does not include identified payer or provider organization level data. That data will be included in a second report coming out a week from today, May 9th, the 2023 annual cost growth trends report. So that will have cost growth trends between 2020 and 2021, again at state, market, and payer and provider organization levels relative to the cost growth target. And there will be no performance improvement plans or other accountability mechanisms for that reporting period, but it is a public reporting period. So those reports will be interesting to hear. And both of those reports and more will be discussed at the cost growth target public hearings. It'll be held in 2 parts this year. If you recall, last year was the first time we had done it. Oregon Health Policy Board helped host it, kick it off. It was exciting. This year's hearing split into 2 parts. First is May 17th and then September 14th. At the May 17th hearing, it's going to focus on presenting the data from the 2023 report. So including provider and payer level data. It is a virtual meeting. More information is available on their website, and I think Tara already put a link into the chat. And then part 2 of the hearings in September will focus on kind of perspectives from the 2020-21 cost growth trends. And we will all be invited to those meetings, so keep an eye for a calendar invite. Really appreciate liaison to that committee, Bill Kramer, playing a role in that hearing. And I'd like to open it up if any other board members are interested in playing a role in that hearing, facilitating, hosting, otherwise, please speak up. Bill, any comments?
Thanks for the introduction, Kirsten. I think these are very important reports, and I'm very much looking forward to the May 17th meeting. It's primarily an informational meeting to try to understand what are the cost growth trends in Oregon to help lay the foundation for the important work going forward. If I could also take a minute, Kirsten, on the healthcare market oversight program. I appreciated seeing the report in the meeting materials. I know that the Oregon that healthcare market oversight program is not a formal committee of the Oregon Health Policy Board, but I think it's a very important one for us to attend to. And I would like to request for future meetings that in addition to written reports, that we have some kind of presentation. And I think there's, for instance, in this case, there was an important decision made, findings and decision about the what was a proposed acquisition. And I think those issues are important to have greater public awareness and opportunity for at least commentary or questions from the board, even though it's not a formal committee. So I'd like us to make that request to the Oregon Health Authority regarding that program.
Great. And I think it is valuable for us. I mean, part of the reason why those reports come to us is so we can have a reflective review of how it's going. John, I see your hand. And I think it's important for us to the board to look at the state of the market. What is happening to our independent hospitals? John, go ahead.
So just wondering, is the May 17th meeting virtual or live?
It'll be virtual.
And any sense of when we're going to move towards, in-person meetings again?
That is a good question that has been discussed, and I don't remember the answer to it. Tara, do you mind popping in?
Sure. Hi, John. Thanks for the question. And we're currently in the process of, we've sent out a couple doodle polls to the members to inquire when we can, people's availability for an out of area meeting or retreat this summer. So we're looking forward to having our first in-person meeting, and it will likely be out of the area in one of the congressional districts that we're required to meet in. All 6 were required to meet in biannually. So we're looking forward to doing that this summer.
Thank you, Tara. John, any more questions?
Nope.
Okay, great. Okay. Follow up. Let's have a cost growth target discussion. Okay, so on today's agenda, we're going to cover the topics of Oregon Health Authority agency updates from Dave Baden. We'll have a progress update from the staff with the Bridge Healthcare Program, an overview presentation followed by questions and answers on the upcoming recruitment process to fill the OHA director position. Update on the Oregon Health Plan redeterminations progress from the Oregon Health Department of Human Services and the Oregon Health Authority. And there are 2 OHPB legislatively related updates to share with members. And we have time for public comment if anybody would like to sign up. And then we'll conclude our meeting with any final comments, questions, or suggestions, and then adjourn. So our first order of business is to vote on the April 2023 Oregon Health Policy Board meeting minutes. The draft minutes are listed as attachment number 1 in today's meeting agenda and posted to the OHPB website for public viewing. Is there a motion to approve the draft April 2023 OHPB meeting minutes?
So moved.
Second.
Thank you, Bill and Brenda. All those in favor of approving the April 2023 minutes, please say aye.
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 I,
Any opposed or abstained? And the meeting minutes are approved. Thank you so much. Scroll down, sorry. Next, I'd like to introduce Dave Vaden, OHA's interim director, joining us today to provide some agency updates. Good morning, Dave. Thank you for being with us.
Thanks, Kirsten. Good morning, everybody. Happy to be here today. Yeah, happy to talk about a few things and answer any questions, chat about what's top of mind for folks. So first, Kirsten, you're doing a good job chairing the meeting. Thank you. So I did want to sort of follow on the cost growth target work and sort of the reports that are coming out. First, just thanks so much for sort of support from OHPB and push for this program, the support for the healthcare market oversight program, and the work that is happening here. I think for me, this is it's sort of revolutionary, evolutionary work, right? It's, we are, I think, a bit on the cutting edge of trying to assure that we are reporting and having some, sort of system accountability, and really looking deep at sort of some of the why, and having conversations as we get to that point with systems and providers about cost. And I think that's, it's exciting, and sort of the evolutionary is that this sort of a year over a year piece. It's sort of exciting news when it happens, and just the hard work for the team in between to get all of that. And I know having the team come back and present and chat with you, I know that they're eager and willing to do that. Just understanding the priority from OHA and the board, and then just sort of taking a step back of again, why. I think, as you all have said many times, and it's shown in report after report, is the impact of high healthcare costs leads to negative impacts for people in Oregon. Just sort of at the most brass tacks level, why should we care? Is because the impact on Oregonians. Oregonians have been delaying care, have difficulty paying medical bills, using up their savings, or filing for bankruptcy to pay medical bills. Understanding the impacts of inflation and other pieces on the market for sure is important, but at the end of the day, having people to have to pay more for their healthcare has real impacts on people. And obviously, we want better outcomes, for people in our state. The program helps create accountability for how much healthcare spending goes up each year. And as I said, the program will help identify what is driving high healthcare cost growth in Oregon, and opportunities to make changes to improve affordability. Not all spending is the same, and there are some pieces where clearly seeing more spending in areas is good. So there will be opportunities, I think, for through this work to really highlight amazing things that are indeed happening out in the health system and providers. So there's both a focus on, cost growth that I think we would love to see contained, but where also, to highlight some of the good pieces that are out there. I will just say we very much are continuing to do this in partnership. There was a partnership, I think, in the legislature to get this program started. Working closely with hospitals, provider organizations, obviously with the legislature, health economists, others around the country. the goal here is that this program is reasonable, flexible, and takes various things into account, like rising inflation, clearly the impacts of the pandemic, and increased cost for healthcare workers. So I think the one of the cool pieces of this is the flexibility that's built into the underlying statute and what the cost growth target work group is able to do. So exciting to have a couple of reports come out. So I wanted to talk a little bit about the two reports that we have coming out. So the first one that's coming out later today talks about healthcare spending and healthcare cost growth in the state between 2018 and 2020. So we're into the lovely pandemic timeframe, at least starting to get here of sort of impact on to the market. So I think if looking at sort of national trends and other reports that have been coming out, I think at the sort of the top spending level, the report I think will not necessarily show a lot of surprises. It's kind of expected what we expected to see for this time period. Generally healthcare spending grew between 2018 and 2019, and then fell slightly between 2019 and 2020. Again, that's especially at that beginning part of the pandemic due to fewer people accessing healthcare in the first part of the pandemic. The pandemic greatly shifted healthcare demand, which impacted spending as people delayed or canceled care. That will be very clear. Again, that obviously reflects national trends as well. Just a couple of other things I want to highlight. Retail pharmacy spending has consistently been identified as a primary driver of healthcare cost growth in Oregon. And pharmacy spending is one of the only areas where costs continued to grow between 2019 and 2020. And that's even after pharmacy rebates are taken into account. Again, I don't think that's surprising than looking at national data, but it is one of the spots that's a little different as compared to physical, behavioral, and dental healthcare. Again, this is really sort of that next report that really gives insight into the key cost drivers of healthcare, gives an opportunity to to really come together to address continued growing affordability concerns across public and private markets. So that's the report today. Again, sort of continued foundational work for cost growth, that looks at different categories of spending. So next week, as Kirsten mentioned, there also will be a report, the 2023 cost growth report, which will present data from 2020 to 21 and also include payer and provider organization cost growth relative to the target for the first time. So this again is the evolutionary, revolutionary part of this, is setting sort of these foundational reports up. And then now we'll be presenting data as the statute requires OHA to do about payer and provider organizational cost growth pieces. The public hearing, as mentioned, is on May 17th. We'll for sure go through lots of time to go through reports and questions there. I know that, as Kirsten said, OHPB members are invited to attend. I know that Kirsten, Oscar, and Bill help in facilitating and opening remarks on behalf of the board. So really appreciate that. Let me stop there. I've got a couple of other pieces, but just see if there were any follow-on questions that I probably will just kick to follow up from the HICMO team, but I'm always happy to give it a shot. All right, so again, so exciting, a couple of exciting things coming out over the next couple of weeks on cost growth work. All right, a couple of other quick updates and then happy to see what else is on folks' minds. COVID-19 and, just sort of outlook. Dean Seidlinger had a press conference last week and a press release back on April 21st. It generally is the outlook continues in a sort of a generally more positive way than where we had been around, cases, deaths, and hospitalizations continue to decline. There clearly are other variants and other things that are on the horizon. That new sort of XBB 1.16 variant, other sort of Omicron subvariants that are there coming out, OHSU forecasting data, that will have sort of little differences in cases and probably some hospitalizations. But I think just generally due to the projected sort of mild impact generally of that subvariant on sort of the intensity of the virus, that again, sort of a generally positive overall outlook for COVID-19 in the coming months, and that this next sort of subvariant wave is that we feel pretty confident that we can measure that. We finally dropped below 200 hospitalizations in March, and we sort of are at like 170 or so hospitalized COVID-19 positive patients. It sort of varies each week in going. Just a couple other pieces. We have been really counting on support from the Federal Emergency Management Agency for our general COVID response. As with most things around COVID, the ending of the public health emergency on May 11th ends our sort of that part of the emergency. The Stafford Act emergency that triggers FEMA dollars also ends. So this ending of the PHE with all of the various sort of federal pieces that are tied to it coming to an end, it definitely is a little bit of seeing how then things go from there, as we assure that there's not sort of rebound or other pieces around COVID generally. We are working, the state still does have some underlying rules around K through 12 and healthcare vaccine mandates that are being looked at. So I think they're as obviously mask mandates and others have gone out, we're looking at assuring that we're sort of in line with all sort of federal rules. I saw President Biden made some changes yesterday as well. So we're assuring that we're following along and making sure that we have sort of the best guidance around where the virus is related there. I think generally just a couple of other pieces around things going on. We issued a statement around the medication abortion drug mifepristone, and work closely with the governor's office and OHSU about working to have a stockpile of mifepristone in the state, which now is in the state at OHSU. Obviously with all of the Supreme Court and other pieces around various cases in Washington and Texas, and watching that very closely to just assure that patients and providers that mifepristone and abortion remain safe, legal, and available in Oregon. So just really have been working hard and more to come around reproductive health and the like. Other than that, probably have seen news around the first psilocybin facilitators that we have licensed the first 3 facilitators for providing psilocybin services within the regulatory framework created by Measure 109, the Psilocybin Services Act. So again, service centers will be able to provide psilocybin products produced by licensed manufacturers and tested by licensed laboratories. There are 2 manufacturers that license for producing psilocybin in the state. with some licenses to come. So continuing to move down the path of that work as well. All right, Kirsten, I'm probably getting close to time, but I think we do have time for questions.
We do have time for questions. Go ahead, John.
Yeah, Dave, I'm just wondering if there's any conversation about, a look back on COVID. That's happening on the national level and world level, and comparisons across developed countries about how they did. And
yeah,
as a country, the United States didn't do well. I think Oregon, I think did better than the United States as a whole, but I'm not really sure. And, I think the first 6 months were especially chaotic. And I hope if we have another pandemic, we can avoid what happened in the first 6 months. So is there going to be any look back in some neutral, way about how we did and what we should learn from it?
Yeah, thanks, John, for the question. So the legislature actually asked us, especially focused on sort of the public health response and public health more generally. And I will try to find those reports. There were some reports done by the Reed group that looked at various aspects of the public health response and made some recommendations generally about that, John. So I'll find those, send those to Tara, and make sure to get that out. And then happy, if there's sort of interest from the board to have that topic come up in a little bit more in depth from Rachel Banks or the Reed group, I think they would be happy to come and chat about that. But Tara, I know I've got them somewhere. I'll find them and send them to you so that you can get out to the board.
And Dave, were those just written reports to the legislature, or was there a oral presentation as well? If there was, if the video could be sent as well. I
Yeah,
guess.
let me check. I will check. I don't remember that piece, Kirsten.
Any other questions from board members to Dave?
Yeah, I knew Tara would find it in the time that I gave her to look for it. Thanks, Tara.
That's to Stacy Schubert. She helped me.
Thank you, Stacy. Thank you, Tara. Melina, go ahead.
Yeah, hi, good morning. I was just wondering, is there any concern with the low booster uptake in Oregon, and what are we doing with that or for that, or plans in the future?
Yeah, thanks, Melina. Yes, I think any of the sort of ongoing, vaccine uptake, and especially sort of the new recommended booster for 65 plus, and those less than 65 with some sort of certain underlying conditions. We still will have active communication work that will be ongoing. I will say less than we obviously used to around COVID vaccine and pieces. Working hard to still continue a lot of the Spanish language outreach through social media, through Spanish language radio, et cetera. So sort of those safe and strong billboards and other work, we're still trying to keep some of that active going forward at, for sure, less than what it was in the midst of the hardest parts of the pandemic. So yes, and I think through additional resources coming to local public health, we still are supporting community-based organizations generally, and sort of this and a variety of other things to continue to try to get messages out about efficacy of vaccine and the importance of continuing to get booster, especially for older people in Oregon, for sure.
I'm gonna slowly pause a moment in case any other board members want to raise their hands or come off mute.
I have a question, David. So long COVID and the rising cost of what potentially could happen. We're going almost 2.5 years out of COVID. Do you have any data in regards to the state of Oregon and how that plays out?
That's a great question. I have not seen anything to me about any Oregon specific long COVID data. Let me double check with our epidemiologist folks and see if there's any Oregon specific studies other than some of the national things that I'm sure Sandra, you and I have both seen about long COVID, but I'll check specifically on it if there's any Oregon specific stuff.
Thank you.
Yeah, this is John. This makes me realize, I think I may be the oldest person on the board. I've heard nothing. I've heard nothing from anybody about the round of this vaccine other than what I see on the news that it's been approved. But my very integrated health system hasn't sent me anything. I spend 2-3 days a week in an independent retirement facility with several hundred people. And it's interesting, I've seen nothing posted on any of their boards or no activity around, that very high risk population getting that booster. So it seems pretty quiet out there in terms of getting to the elderly population, at least from my, I guess, fairly isolated point of view.
Well, John, if you need to up your social media game, there's definitely been, I've seen a lot of OHA postings about this, and we have highlighted it in our sort of regular newsletter publication, which has over 750,000 subscribers, larger than any newspaper or other publication in the state. So we have done it a couple of places, but I think your point is well taken.
It seems like social media to reach a senior population might be a tough match. But great. Any other questions from board members? Okay, then thank you so much for joining us this morning, Dave. Appreciate having you here and you filling that role.
Yeah, thanks. I hope I should be able to be around all morning and listen in.
Great. Okay, our next agenda item will be is the Bridge Healthcare Program. Policy analyst Tim Sweeney and Laura Swerdlow with OHA's Health Policy Division joining us to share updates with the Basic Health Program. Thanks for coming back, Tim and Laurel, and you can begin when you're ready. I see you, Tim and Laurel.
Morning. Good morning, everyone. Thanks for the opportunity to return and offer some additional updates and really information on the progress as we develop a basic health program in Oregon, which, as a reminder, it will provide CCO-based health coverage to adults with income between 138 and 200% of the poverty level. I'm Tim Sweeney. I'm the policy lead for this project. And as you mentioned, Laurel Swerdlow is here, our project lead. I think that we have some slides. There we go. Great. Well, thank you very much. Last month, we joined to present a draft blueprint in advance of public comment period and a tribal engagement process that both formally began yesterday. And today we have a few brief updates related to guidance from CMS that we received since that last meeting, and our ongoing conversations with CCOs about implementation and really the operation of a BHP. So first I'll start with the CMS updates, which are on the next slide. And really a bit of good news to kick it off is that on Thursday, April 20th, Oregon received formal approval for the temporary Medicaid expansion, which will enable people who go through the redetermination process and are identified as having income in this 138 to 200% of poverty range, people who will be eligible for the BHP once it launches. This amendment will enable them to remain on OHP while we finalize and get the BHP ready. Really depending on exactly when the BHP launches, we're targeting April to July of 2024. We anticipate that this temporary expansion will ensure coverage continuity for potentially 50 to 60,000 people between when they go through the redetermination process and the launch of the BHP. Next, related to the BHP, we got some revised guidance from CMS related to program implementation. And in this guidance, CMS informed us that we cannot, as we initially planned, implement the BHP first in a manner that limits enrollment only to those people who are already on the Oregon Health Plan. Basically, we must allow other eligible people also to enroll when we implement the BHP. And so we're working with our federal partners, with CMS and Treasury, who oversees some portions of this, really to finalize details that would enable this still mid-year launch of the BHP in 2024, to do that in a way that also minimizes disruption for people enrolled already in marketplace plans. And so the next couple of slides really highlight our implementation plan at a very high level, and especially based on how people will access the BHP depending on their coverage situation. So the next slide shows for people who are already on OHP, they will transition to the BHP when it is implemented. Again, we're saying sometime between April and July of 2024 is the target implementation date. At that time, people who do not have health insurance coverage would also be able to apply and enroll in the BHP through existing application and eligibility portals. So taking a look at the next slide, folks in this income range who are already enrolled in health coverage through the marketplace, there is a little bit more detail to explain. First, it's worth noting that nobody will be automatically moved from their marketplace plan to the BHP in the middle of the year. Instead, these folks will have to either update their marketplace application or apply to the BHP directly through state eligibility portals. People who do this, people who choose to do this, are then and are determined eligible for the BHP would no longer be eligible for marketplace tax credits. But again, just to make note, it takes that conscious action to update the marketplace application or to seek the BHP through the one system, for instance, or a paper application. If people don't do that, they will stay enrolled in the marketplace plan that they've already enrolled in. Furthermore, I think it's worth noting that even beyond this mid-year launch, there's again not this automatic move where somebody is automatically enrolled in the BHP. Therefore, some BHP eligible folks are expected to remain in the marketplace because they will automatically re-enroll in their current marketplace plans, in some cases into 2025, maybe into 2026 as well. So really full migration of people from the marketplace to the basic health program will happen over a couple years, really through the end of 2026. So I want to pause real fast here. The second half of this is more about our work with CCOs and how we're developing the operational and implementation details. So I wanted to stop here and see if anybody had any clarifying questions on this CMS guidance, I think we'll have plenty of time, I think, for a conversation about it, but just in case there's anything to clarify.
I definitely have a question and sorry, it's harder for me to see when hands are up, when slides are up. So if I'm missing any board members asking a question, please just interrupt. For this last population that you talked about, people who are in the marketplace, who are potentially auto re-enrolled in their marketplace plan up through maybe December 26, will they continue to receive their tax credits for that same period?
Yes, that is the intent. We are working with CMS and Treasury to get, I's dotted and T's crossed to make 1,000% certain that this protection is there. And just to add, this is consistent with how states that have implemented the ACA's Medicaid expansion in the middle of the year have gotten their residents treated by, in terms of maintaining eligibility for their tax credits if they stay in their plan until they choose to enroll basically in the BHP or in those cases in Medicaid.
Okay, and just to put a finer detail on that, it's people who auto enroll in their same plan, but if someone was to be like, I want to switch plans, then it's like, if you're gonna, is it something like, if they're gonna switch plans, well, no, then you need to go to switch to BHP.
Yes, that would essentially entail updating their application. If they go in and confirm their income and put in new information, then they will get identified as BHP eligible and kicked to the state systems for the final determination, just as they would if they were Medicaid eligible, but for the final eligibility determination and then enrollment in the CCO.
Okay, thank you for making that super clear, Tim. And also thank you for, I love your 1000% sure, because it is that critical of a question. So I really appreciate your dedication to tracking that down.
We plan to get this essentially codified in the blueprint that we're submitting. We have made edits to the blueprint that y'all saw last month to reflect this enrollment strategy, this implementation plan. So we are trying to, again, get 1,000% and get this in writing from the federal government.
Excellent. John.
Yeah, Tim, thanks. This is really interesting. And I'm just interested in, is there any prohibition on the marketplace plans or brokers and agents from marketing the population to stay in the marketplace, or the CCOs from marketing the population to move? In other words, is marketing going to be allowed in terms of the private companies involved in both options?
There's no prohibition for marketplace plans. I don't know what exactly they would do to try to keep their members from applying and moving to the BHP. There's no prohibition on that. We do expect some communication from CMS to tell people that there's that something has changed. We don't think it's going to be like, hey, go enroll in the BHP, but we do expect some communication from the marketplace, but it's unclear exactly what that will say and how that will affect folks' decision. I also saw Laurel come off mute, so I want to pause for a sec.
Yeah, I just wanted to offer, John, that I think the question that you're asking is one of the main pieces that we're still trying to work through in the wake of this decision that we received from CMS just a few weeks ago. We have, as you'll see in a second, a timeline with the top topics that are top of mind for CCOs, and communication to enrollees is one of them. And the main question that we're going to be asking is, what is the scope of the communication that OHA and CCOs will be engaging in now that we have this new information about a mid-year launch? So I second everything that Tim is saying, and I also want to underscore that this is you're honing in on what is very much top of mind for us and something that we're still working through.
Thanks.
So
On
I have
that, oh,
I have a question real quick. So is this going through the marketplace exchange, or is Oregon going to their own platform? So that cost associated with going through the federal system, is that different now? Or I guess,
so
or is it just the insurance package?
So this is not the product. The BHP will not be offered through the marketplace. It is more akin to Medicaid. It will be through the one system, through the way the state contracts with CCOs. Separately, the effort to have a state marketplace platform, it exists at the same time. I think the connecting point is that if somebody applies for health insurance coverage through the marketplace, but instead their income suggests that they should be covered through the basic health program, that information will then get sent from the marketplace, whether it's the federal platform or the state platform. That information will get sent to the one system for the state to do final eligibility verification so that the applicant can get then enrolled in the CCO. I think big picture, once the state moves to its own marketplace technology, that will have more control over the interaction between those two systems. But even while we're on the federal platform, if somebody tries to get coverage through that direction, they would still get connected to the BHP. Does that?
Yeah.
that
So I'm just curious. I mean, because even we've had the system for quite some time, went from the a platform through the state and then on to the federal platform and then back. It just, sometimes it was really confusing for clientele or patients to I guess navigate through the system. So, and with OHA, it was always difficult to get enrolled. So I know the one system, I mean, we've been through numerous systems, but I'm just, the one system is really going through DHS via OHA. So I guess I'm just curious how that's actually going to be convenient for the user. So
yeah, I think broadly speaking, this is certainly a focus of all of this work, is making sure that these transitions are as seamless as possible. And I think one of the reasons why having this go through the CCO system will help is that we think the coverage transition at 138% of poverty, basically when somebody would have left Medicaid and had to go to the marketplace, that transition will then get much more seamless, because when somebody goes through their renewal and is determined that their income is now 150% of poverty instead of 100, they won't have to leave their current CCO coverage. They won't have to leave the health coverage that they have in order to go enroll in the marketplace. They will just have their information, if you will, moved from one category of coverage to another, and they would keep their same CCO and their same ability to see the same providers. There will always still be whatever programs happen, like transitions between systems, and I think that's one of the that is certainly an area of focus that we're making sure that we're doing as much as we can to connect people moving between those systems, and that is certainly going to be happening a lot with the redeterminations effort, and I think we'll be able to learn from that moving forward as well.
thank you.
Yeah. So maybe pivoting back to the slides, and really and I think this is all relevant to these next couple slides too, and then the next slide shows starts to talk about this conversation we're having with CCOs. We convened a CCO table back in the fall at the direction of the task force, and then we've talked to y'all about this and are continuing to meet with them on a variety of operational and implementation topics. And in these meetings, we're responding to questions the CCOs have and really trying to work with them to develop the approach on these key topics. So far, we've put together an operational timeline for them, and we'll show you that in a second. We've discussed how health-related services and value-based payments would theoretically exist within the BHP. And some of the next conversations are other aspects of the Oregon Health Plan to figure out how that connects to the BHP, the quality pool, directed payments, and as Laurel mentioned, discussing communication strategy for when this program gets implemented, and certainly transitioning folks between the BHP and the marketplace. And the next slide really takes the next step of detail that we've put together, and I know this is probably very small on the screens, but this within sort of some of the broader categories on the last slide, there's a lot of very specific questions that the CCOs have about how rate setting is going to work, about how they're going to work with providers, about what kind of information they're going to get through what systems and forms. And so we're putting this together to make sure that we're working through all of both the big picture and the very detail focused operational questions that the CCOs have in their mind. And it's being regularly shared with them to make sure we're capturing everything, and that the timing for when decisions will be made works with the overall implementation timeline to launch this program next year. And finally, the last slide shows a little bit more detailed timeline for the blueprint work that we're in the middle of. And that really is, I think, part of the impetus for this conversation, because it's coming back to you in a couple months for approval. So we've spent the first part of the year developing the blueprint, and as I mentioned, starting May 1st begins a 60-day tribal engagement process and a 30-day public engagement, public comment period. And in June, we'll integrate feedback and finalize the blueprint to bring back to y'all at the July meeting. With that, I'm sure we're probably getting close to overtime, so I'll stop, and we're both available for more questions.
Great. We certainly have a couple minutes for questions. If any board members would like to raise their hands or come off mute, go ahead, John.
Yeah, the slide with the detail from the CCOs is interesting. This really isn't a question. It's just a statement about an interest of mine, but I think others are. We know that the price factor is significantly different between commercial and Medicaid. In fact, likely the price factor is double in commercial compared to a Medicaid. And so this makes me wonder, I'm not sure what the price factor really is for marketplace folks. They're on the private side, they're covered by insurance companies. And I wonder what that price factor is. And as I look at those questions, it certainly seems the CCOs are exploring, well, what leeway expectations are there in terms of price for this unique population. And so, from my point of view, at some point in the future, I would sure like to have some sense of where that ends up. What's the price conversion factor for this population versus Medicaid versus other marketplace populations versus commercial. So very interesting work. Thanks for sharing it.
Thanks, John. I know you said that was more a comment and not a question, but we do have a bit information on what you just brought up. So if I may just offer a bit of insight. So the House Bill 4035 directed the agency to be considering capitation rates that would enable higher than OHP provider reimbursement rates. The task force considered this as a priority in part because OHA and the task force acknowledges that those higher reimbursement rates on the marketplace side really help supplement the lower reimbursement rates that providers experience on the Medicaid side. The task force ultimately recommended that OHA begin with setting capitation rates that are on par with the capitation rates that CCOs receive for OHP, acknowledging that over time, we anticipate that the BHP Trust Fund will grow. And as the BHP Trust Fund grows, the direction from the task force is for OHA to begin to enable those higher capitation rates that enable higher than Medicaid reimbursement rates. House Bill 4035, just as a reminder, is was the legislation that was passed in 2022 that directed the formation of the task force and directed OHA to be pursuing a permanent coverage solution for this population.
Thanks.
Yeah.
I have a somewhat not totally related question, but along a similar vein around the medical loss ratios. What is the, and I'm familiar with medical loss ratios for the marketplace plans. Can you talk about, and maybe you don't know the answer to this because I see it as one of the CCO questions, but yeah, what will that transition be like? Will there be a shift for these plans?
So the MLR requirements, the minimum medical loss ratio requirements federally for the BHP is 85%, which I think is the same as in the marketplace. So maybe that's not exactly right. But I think that it is. And so in the short term, I believe that there are always conversations around like what the Medicaid MLR is. And I think the questions are really around, if changes are made to the Medicaid MLR, does that affect BHP? Is this one across the programs? Like, how does that work? And I think the way that we've been talking with them is really around what the federal requirements for the BHP are, and making sure that we're all clear about what implications it has for the Medicaid MLR. And understanding really that in creating a new program is maybe not the best time to get super aggressive with some of those financial requirements.
Great, thank you. Any other questions? All right then. Well, thank you so much, Tim and Laurel. Appreciate your work, and we'll look forward to seeing you back here in July, where this final blueprint will come before the board for approval. And I did want to highlight something that Tara put in the chat around an educational webinar in June about the marketplace. So thank you so much.
Okay.
Our next agenda item, we are running just perfectly on time, everyone. Next, I'd like to welcome Chris Katz, OHA's Deputy Director, joining us today to share updates about the recruitment process to fill OHA's director position. We heard from Interim Director Dave Baden at the March meeting that efforts would be underway. And so Chris is here to fill us in about what those are. And thank you for sharing information with us today, Chris, which is obviously something near and dear to our work and to the agency. And so it's nice to have you back at another meeting. Go ahead.
Thanks. Good morning, everyone. And thanks, Kirsten, for the introduction. It's good to be back with all of you again. So a little bit on the director's recruitment update. I actually thought I would have a little bit more detail to share with you today. However, in working with the governor's office over the last couple of days, we are going to slow what we were starting to put into place down. And let me share with you. So we are actively behind the scenes working on a recruitment process. And the recruitment process involves the governor's office, the Department of Administrative Services on behalf of the governor's office, as well as a third party who has been hired as an executive search firm to do agency director recruitments, OHA included in that mix. And so as the governor's office has had the opportunity now to work through this process with other agency director recruitments that went before us, so to speak. Department of Ed, Department of Ag, Oregon Liquor and Cannabis Commission. They have all been actively in the process of recruiting for new directors since the beginning of the year. And in that, of course, with any process that is different than what it had been in the past, there is an opportunity to make adjustments to it before we launch into the department's OHA's director recruitment. So we are going to have a meeting here, hopefully late this week, early next week, with all of those parties together to make sure and confirm what is the process and who's responsible for what pieces and parts of the process. But included in that process, of course, will be engagement with interested parties, communities, and those types of things. And so in order to bring, and for OHA, as you can imagine, there are a lot of those, a lot of different communities that we work with, a lot of different interested parties, et cetera. And so how do we gather all that information from people and include them in the process and ensure that in the end, the governor and everyone finds a person that can meet maybe not all of those expectations, because right, unicorns don't exist, although we wish they did. And so we hopefully by the time of your June meeting, I will be able to provide you with a lot more detail and information about how the process will move forward, how to involve different people in that process, and be clear for you on timelines, milestones, and those kinds of things. As I said, literally, I was ready to be a little bit more detailed today, and based on some feedback that the governor's office was getting from others involved in those other processes for directors in other agencies, we want to make sure that as we move into this process, we can streamline and ensure that we get the outcome that we're looking for in the end. So really today is just an update more than anything else to say lots of work behind the scenes, and hopefully by June, I can be much more detailed with all of you about the plan moving forward. With that, I'll take any questions. I don't have much detail, but happy to try.
Okay. I think this is a shift from I think the conversation we had all expected. I would like to welcome board members then, in light of this shift, maybe we can be proactive. Like, how should the Oregon Health Policy Board be involved? And I think, if there's not a structure directing us on how that is being envisioned, maybe we'll take this moment to envision it ourselves. Brenda, I saw you come off camera.
Yeah.
Any thoughts you'd like to share?
Sure. Chris, thanks for the information. I know it's kind of one of those challenging conversations of, well, we thought we were going this direction, we're making a course correction, and I appreciate that. I personally think it's really critical to do the job well and to get it right. So one of the, I guess, comments or questions I have, both along with where Kirsten was describing of how we're envisioning the role of the board. That's one question. I think the follow-up to that is, are there specific critical qualifications or criteria that the search group is looking at that we can also kind of include our thoughts in it, or a specific like ideal candidate profile that the recruitment group is contemplating? So thanks.
Yes, thank you for the question. I think that's one of the key challenges, that as we do this work and go out and meet with interested parties and community groups, how do we do that listening for what people want, and turn that into those desired attributes, critical key skills and abilities that a applicant may have and is desired for this position. And so it is trying to focus and hone in on some of those inputs and how to ensure that not only this particular board, but as I said, the many communities of interest across OHA have that opportunity to provide some input. And then how do we ensure that that is seen? And seen is maybe a poor term, but how is that reflected in the process, in the applicant screening, in all of those details behind the scenes? How does that play out? And we need to work on that process a little bit. And the goal is really to include key partners, again, and communities in the process, the how to do that, to get to what are the attributes people are looking for, how do we ensure that those play out through the process to the end goal, and having communities, having interested parties, having the governor and what she's looking for, how do we converge all of that data together?
Thanks. In follow-up, I'll just make a comment, and I suppose there might be a question in there too. I recognize the important balance of doing really strong and thoughtful inclusion, which I believe is what you're speaking to,
Yes.
while also balancing the sense of urgency, around the importance of this role and stabilizing the leadership within the agency, thinking about, these major bodies of work that in some ways feel like they're set aside. We're moving them along, but not without, anyway, until this decision is completely landed. So can you speak to the other side of the equation? You spoke to the inclusion. Can you also speak to the timeline and sense of urgency?
Yeah, so thank you, Brenda. When I first initially spoke with the governor's office about timeline, we talked about 6 months. And that would put us about September to have a candidate that was ready for candidates ready for consideration by the governor. So it would include engagement, it would include more traditional, maybe, interview specific type processes, a honing down of the pool of candidates, et cetera. I still think we're on pretty much that timeline. There is, like I said, there was a whole process we were ready to put in place, and we're checking ourselves given the experience of others before we launch. And so we're pretty close to being there, but we need to have one more meeting again to make sure we're all on the same page. We all have the same timelines in mind, and we're all agreeing to the outcomes we're looking for. And so we'll get there. And but I'm hopeful that by September we have the final group to the governor for consideration.
Thanks, Chris.
Mm-hmm.
And Chris, do you think that timeline means that the HPA director position recruitment is on pause until that OHA director is hired? Or do you have any update for us about that position?
That's a great,
to this effort?
Yeah, that's a great question. So we are also going to launch the HPA director recruitment. In the meantime, I think what you will find is that we will probably try to step them, i.e. a new director comes on board and a new director then gets the opportunity to look at the final candidates for the HPA director, right, in that process, so that hopefully we can time that here in the not too distant future. We haven't opened the HPA director. We're still working through developing a recruitment plan for that position, and hope to have that moving forward as well, and cognizant of this process, that process. And we have other key positions as well, like the chief medical officer, et cetera, that we are also looking at in this whole recruitment game.
I don't want to hog the mic here, so to speak. Great, Brenda, go ahead.
Yeah, thank you, Kirsten. I don't know if Dave is still on the call. Oh, there you are. Hey. So given this conversation, I'm really curious around perhaps helping educate us as a board about the kinds of initiatives that we're carrying water on, but we're not really doing deeper dive work into. And this is more the agency view overall. Between now and September, if we follow Chris's kind of timeline, then we have a lot of other leadership positions that we're putting in place post-September while we're recruiting, and in the process, the sequencing of really having the right team on board sounds like it's significantly delayed. So what I'm curious about is, therefore, what are the kinds of projects, initiatives, efforts that the agency is going to be full tilt all in on, just moving the trains as best we can, and those that are going to be suspended until we want clarity around that team coming on board, maybe suspended. Yeah, I think you kind of get the gist of my question.
Yeah, thanks, Brenda. It sure feels like there's a lot of water that we're moving right now. I think a couple of pieces I think are resonating based on that question. I mean, first, the importance from the governor on down of assuring that the waiver is implemented successfully. Focus on obviously all pieces related to that, full bore with the legislature to make sure that it has funding to be successful. So that is for sure a big priority in that space. Obviously the work around behavioral health and assuring that sort of sets of initiatives around behavioral health kick off well. Lots of that work in the legislature to see sort of funding and other pieces that come from there. Redeterminations in the midst of all of these things. I think these are all sort of the big briefing issues that we're bringing to you. I mean, I think the piece that I think the agency will be looking at and moving into, as I wouldn't have said necessarily that, although there's always a lot of important work going on, there will be things that are a little bit more getting ready or futuristic. So one, the Medicaid tax packages from hospital and provider tax will be up, not this next biennium, but the biennium after. So being able to have a full, thoughtful discussion about Medicaid financing and, just having full partnership and a move toward those conversations will be important. There's just a lot of other pieces from health-related social needs benefits and other pieces that are coming into Medicaid from there. Clearly, further discussions need to happen on workforce, healthcare workforce, behavioral health, sort of full bore on workforce. There is obviously work going on there within the agency. I think as we sort of come out of the session, work through sort of some hot burning sets of implementation issues. Workforce, I don't want to take away for 1 second that workforce is not a burning issue, but I just think a piece that will clearly be a strong focus going forward. But will we have enough bandwidth to really dig into that piece as an example, Brenda? So I think there's sort of sets of things that I know I have heard very clearly in my role that that I need to pay strong attention to. Implementation of the waiver with a strong focus on the implementation of these new health-related social needs benefits, especially with a focus on housing. All sort of systems to try to focus on behavioral health, supporting Governor Kotek's priorities. So, you know, that is what I'm trying to organize around the director's office. You know, I've brought in a couple of folks to help in the director's office in the meantime. So we're definitely moving forward on those key priorities. But it is a fair question. I think the some of the issues from you know, CCO contracting and pieces, I think those we will be moving to as we get into sort of the fall and the winter would be my take.
Thanks, Dave.
I will just add on to that Oscar and I are having conversations with the governor's office so that we as a board are getting feedback on priorities and information. So as we head into our retreat to kind of renew or re-identify and set the board's priorities and what is the water we're carrying, that we're not waiting till this position is filled to do that. We're gathering the information now, go into our retreat with it, set it, and find a partner in this position, hopefully. But that we are hoping to not be on pause. Working to not be on pause.
Yeah, thanks. I appreciate that too. Thanks.
Any other board members? Well, Chris, I feel like you got the hot seat today, and I'm sorry. I know this is not you, so I appreciate you
No worries.
being the face that answers our questions
You bet.
and gets our reactions to this new.
It's all good.
I don't know if you're able to identify this, but I appreciate the, like, you know, there will be a community engagement plan. I was wondering if you could help define for us, like, who is the we designing that community engagement plan?
So the governor's office, myself as a representative of OHA with other, we've had conversations with the leadership team inside of OHA about creating a list, listening to Modus. Modus is the third party that is part of the on contract to do executive search, and then DAS as well. So all of those are inputs and creating that list of community and interested party in the process. And the list is really long, I'm not gonna lie. It's you know, I probably have 30 different either identified specific parties, such as the Oregon Health Policy Board, or I have, you know, community and a number of different related groups underneath it, right? And so it's trying to find that balance of how to do this engagement, how to do it, and ensure that what we get from the engagement is then carried through the process. Modus has done the community engagement with other director positions that they have done. I think the goal is to continue to do the listening sessions, but it's really how we work on the back end then to take that information from the listening sessions and turn that into, as Brenda said, the key and desirable attributes for the candidate moving forward with all of that input, because that can be a challenge to do, right? From different parties all coming together.
But a critical component, I appreciate that. If we're gonna ask, then we need to listen to the
Mhm.
answer.
Yeah.
Dave, go ahead.
Yeah, I just also just a couple of pieces from my end. I mean, for the board, I mean, I think Chris is trying to Chris is laying out broader, like, again, how we are assuring that we're getting a broad set of information on what's important for this next director position. I don't want to take anything away of what OHPB and its unique role for the health authority in setting priorities, assuring that that they have such a key role in, as Kirsten, as you said, of finding the right partner to move health policy and to move the state forward in a really important direction. That I will say, in discussions that I've been in the governor's office as well, that is really important to make sure that we're valuing and having you as part of this process to help find that right partner. So, I think that I just wanted to emphasize throughout this process how OHPB will be a partner in getting to find the next permanent director.
Well, with that, then I appreciate that, Dave, and I think we are anxious, I think, to see this process move forward and to know how the Health Policy Board can get involved, and whether that's more of an open-ended question or here's your opportunity. We look forward to that. And not only for this director role, which is so critical, but also the HPA director role is also historically been quite a partner in the board's work. And so I think when that soon timeline is attached to an actual month, we would like to hear it, please.
I hear you, Kirsten, and would be happy to bring that back as well.
Thank you so much.
Mhm.
Okay, seeing no other hands from board members, appreciate the presentation, Chris and Dave. I think we will move into a 15-minute break. So see everyone back here at 10 after 10. Thank you. Start with unmuting myself. I'd like to call people back. We are concluding our break now. So if you're back from your break, board member, if you could turn your camera on if you're able, no problem. If not, you know, technology is not always our friend, unfortunately. So we are running a bit ahead of schedule, so I'm going to toggle some things on the agenda. Thank you for your flexibility with that. So we'll give a little extra time for our presenters on the public health emergency unwinding to join. And in the meantime, swap that with the legislative update. So assuming that's okay with everyone, we'll keep going. Our legislative update is a little different this month, although our government relations folks are here in case there are any questions. But I wanted to give a couple updates on two things that have transpired. The first is that in some prior meetings, we had talked about submitting testimony on SB 699. This was the bill that was kind of impacting both the Health Plan Quality Metrics Committee and the incentive program, metric incentive program, as well as did some stuff with funding. And the board had talked about submitting testimony in favor of this, in part out of a desire to align and maximize the use of the incentive program to achieve our health equity goals. But this piece of legislation has had a lot of twists and turns, and I'd say the pathway for the legislation is still being amended. It's in Ways and Means, and OHA plans to further amend it before that is finalized. OHA does plan that the final language should direct OHA to study how to center health equity and community voices within the metrics program. It will also allow OHA to use non-risk payments to phase in health-related social needs spending. So those two things are still staying pretty true, expected to stay true to what we had originally discussed. But given the uncertainty around the bill's pathway in the past months and these kind of tweaks that keep happening, Oscar and I decided against sending a letter in support of the concept. Not that we don't, I think the board remains in support of refocusing this incentive program to maximize progress towards state and agency goals like health equity. But this process just wasn't working for us very well, and so decided to take a step back. I do anticipate that the Oregon Health Policy Board would have a role in shaping that study should the legislation pass, given that both that HPQMC and then metrics and scoring underneath it are committees that report to the Health Policy Board, and because of our interest and commitment in centering health equity in Oregon Health Plan and beyond. But I did want to circle back and close the loop with people that we are not planning to submit that testimony anymore. Are there any questions about that? I've heard, oh, and I said the wrong bill number, sorry, 699, not 966, my apologies.
Oh, it actually is 966.
Oh, I just did that again. I'm sorry.
Thanks for the update. I appreciate it very much. I recognize, or maybe let me just ask this. There's multiple ways to get after what I think the board's intention is. And while the path may not be as clear as we once thought it was going to be, do you anticipate other hurdles that may get in our way?
Of kind of changing the metrics for helping the metrics program to evolve.
Yeah, that's a better frame of it, yeah.
Yes. I mean, I'm sure there's a lot more informed people than I am on this call, but I don't think that that it's not a tweak. And so I think, like so many things in our health system, you know, we're trying to make improvements, and sometimes those improvements have cascading effects, and the problems can be so complex that, like, I don't think this like legislative path is uniquely twisty in creating this change. And I was very interested to hear Director Baden flag for us in a couple cycles from now about this, you know, essentially looking at CCO funding and Medicaid rates and how that's working. And I have heard in the committee meetings of those committees kind of, this is an incentive program, but some people have expressed, because of the CCO rate system, this is not incentive money, that this is used to keep some people's lights on, they felt like. And so, you know, I'll leave it at that there are strong opinions on here on this topic that go beyond the commitment to center health equity even. And so I expect there to be, I would expect there to be additional, potentially additional barriers, that this is not an easy thing. But I invite maybe others who are staff who are more knowledgeable on this issue, if they have any other thoughts or a different way that they would answer this question.
Hey, Kirsten, this is Tara. I just pinged Stacy. She had to jump off, but she may be able to hop on and provide some context, unless perhaps Phil or Ashley have anything to add.
No, I think Kirsten did a great job summarizing. It is a difficult issue. There's a lot of viewpoints, and we're, you know, I think, as we said in past meetings, trying to stay, you know, in fidelity to the idea of putting community voice at the center of potential changes and the pathway to those potential changes. But I think that, as Kirsten said, there'll be many more twists and turns along this pathway.
So happy to come back to this when Stacy is here, or if there are any other comments. I also have another weighty update for folks, or weighty, I don't know if it's weighty.
Stacy's just joining.
Great. Well, Stacy, if you're here, raise your hand or something. Or, oh, there you are. Hi, sorry.
Hi, I am here, and I apologize because I was in a different meeting, so I just missed the whole conversation, but Tara let me know that it might be helpful to join.
Thank you. Sorry. And I'll recap. Brenda, jump in at any point if you feel like I'm not reflecting the question accurately. But I think we were talking about the updates to, let's see if I get it right, SB 9. I don't know. Ashley?
966.
Yeah. Thank you. SB 966. And this path of evolving our incentive metric program to center it in health equity and feature community voice while being an effective incentive program for our CCO program. And do we foresee other barriers along that path? And we were specifically talking about the twists and turns of this legislative effort, but in the bigger path of this change.
Well, it's hard to predict the future, of course. I think it's going to be very important for us to have You know, as per the bill, we will, if it passes, have a contractor assist us in conducting a study to look at the incentive program, and they would be coordinating both with community as well as with representatives of the health system. And I think that'll be very informative and help us to have some ideas of where to go. But you know, it's hard to predict what additional, you know, bumps along the road we could run into. I feel like that wasn't a very informative response, but forgive me for missing the first part of the conversation.
We appreciate you jumping in, Stacy. Okay, thank you. We will look forward to hearing about those bumps on this road as we travel down it. So the other update that I wanted to share with the board is that 2 weeks ago, the Senate Committee on Healthcare asked for a presentation from Oregon Health Policy Board about the Oregon Health Policy Board. So Steph Jerem and I presented to the Senate Committee, and it ended up being in the context of SB 1042, which I will talk about. But basically our presentation and the slides are in the agenda, linked in the agenda, so people can see what Steph and I presented on. Which was essentially the history of the board, outline how we function and what we have been doing and how we set our priorities. And so those slides are there for your reference, and there's obviously a recording on OLIS of it. Oscar and I actually did a similar presentation last fall to the Senate Healthcare Committee. It had a lot of different people on it at the time though. So the reason why they asked for us to make this presentation is that they were having a hearing on SB 1042. And this bill, thank you, Tara, for putting it in the chat. This bill essentially increases the authority of the Oregon Health Policy Board, would give us, well, included but not limited to overseeing legislative concepts from OHA, the OHA director position, it would change member experience and expertise requirement, including behavioral health and public health and active participating primary care physician, give authority over OHA waiver applications, the cost growth target program, and more. It would dramatically change the role and responsibilities of the Oregon Health Policy Board, including funding and independent staff. Kind of dramatically re-envisions and changes the resources of the Oregon Health Policy Board. And so I wanted to highlight this. There were a lot of questions raised by committee members about where and how the board is independent from the Oregon Health Authority, why we work on some topics and not others. And I wanted to bring this up so that the board members are aware of kind of conversations happening about the board and questions being asked of us. And if you have any feedback for me about how I represented us, please let me know. But that there is this kind of, there were these questions, and I think it's important that we take some of these big picture questions about how the board sets our agenda and how we maximize or not some of the authorities already granted to the board as we go into our retreat. And so I wanted to flag this, like we are in the midst of finding the date for this retreat for us to gather in person and really take the time where we identify what are our work priorities over the next 2 years. What does that mean? How do we get it done? And in selecting those priorities, I like to think that healthcare is like a mile wide and a mile deep. And so there are many priorities that could be set, many that are worthy, and we can't take them all on. But we try to be thoughtful about which we set and make sure that we make progress in those. And so we will be doing that at our upcoming retreat. And I think having very honest and at times critical conversations about what we choose to work on and how we move that work forward is important to do. And so I wanted to take this opportunity to let you all know what had happened, and I think like what we take with us into the future from that presentation. Go ahead, John.
Yeah, thanks for bringing this up. I wasn't aware of that bill. I've been involved in some other things where OHPB came up, and wondered, the degree of interest and knowledge about OHPB at the time. But in that case, things went away from OHPB, which I think was the correct decision. Your comments, they'll make me remember the past. OHPB did not have a role in COVID. Remember, we didn't meet for the first 4 months. And I think it was emphasized to us then that the thought was we weren't structured to deal with COVID. And I think that was correct. I wish we would have kept meeting because I think we could have helped in other ways. But I think, while at the time we had David involved, and he certainly had public health expertise, my gosh, but we weren't the place for that, and I agreed with that decision. And then I think some of you recall that during various times we've had discussion about mental health, and the board playing a more active role in mental health. And we went to the state hospital, and we had regular reports from the mental health folks, and we had Ebony on the board. But at the same time, I remember pretty vividly a discussion that concluded that we were not going to be the place where these mental health issues would be sorted out. And while we still have some linkage to the mental health committee, correct? We're not where that will take place, and I agree with that, because those are really tricky issues. So it's interesting that somebody somewhere thinks that should be re-examined. I think I'm hoping that whoever that is, they're looking back historically on those situations and in order to make a decision. I think it's difficult to be kind of all things to all people, which kind of this proposal would suggest. And my own sense is we've been more effective when we have been focused and have had clear-cut priorities and acknowledge that other issues that come up should have the same kind of attention by another group of people who are organized to deal with that. That's just my own 2 cents.
Go ahead, Brenda.
Thank you. Thanks for this. I'm also struck by it being relatively new news to me. So I'm curious if you can speak a little bit to the opposition and support of Senate Bill 1042. And I don't know if that's Ashley or you, Kirsten. Yeah.
Do you want me to weigh in on that, Kirsten?
Sure.
Yeah, so I think Kirsten mentioned in the beginning when she started to talk about this presentation that, by the way, Kirsten and Steph Durham did a really wonderful job, and encourage you all to go back and watch the recording from that testimony, which was on the 17th, I believe, April 17th, in the Senate Healthcare Committee. But Senate Bill 1043 is no longer alive. That bill died in committee, but the public hearing happened afterwards. So just to clarify that. You can also see listed in OLIS that there is opposition from Care Oregon. They submitted, and then Oregon Health Authority submitted some testimony. And then there's 2 other exhibits there from Family Care Health Representative Art Zukorski. I don't know that I pronounced his name right, but there were 2 folks that were presenting at the public hearing kind of in support of this bill, and you can hear the full context if you go back and watch that. And Phil, you might have more to add if you're still on.
Yeah, and I mean, like Ashley said, this bill is not going to pass this legislative session, and I think there seem to be many issues motivating it, and its proponents looking not just historically, like John suggested, but actually nationally about how different health agencies how they have maybe these boards and how they relate, and we're just different. Like if you look at Massachusetts and you say like, oh, well, they have this health policy commission, like we are just not, we are very different than that. And so, you know, maybe those conversations continue about other ways to structure. One of the takeaways that I had from this moment was, how do we as a board reflect on, especially as we go into retreat and are making our priorities, how do we reflect on the role that we play, the priorities that we want to set, and maximizing our effort towards those work products. And John, I appreciate you pointing out that the board has actually in the past been has purposely not picked up the mantle on some items because maybe because we didn't feel we were the best people to make progress for the state of Oregon in those areas. And so I think as we go into our retreat, it's good to look at what are our priorities, how and where can we make the biggest positive impact, and also how are we structured in ways that is working or not working for us. So, you know, we have over 200 people who participate in committees of the board. It is an immense effort by many, many volunteers. And some of these committees don't have liaisons because although our committees have gone from like 3 to, I don't know, I knew this 2 weeks ago, I had the number, it was like 3 to 12 committees, or so. It's like a pretty remarkable growth. Meanwhile, the size of the Oregon Health Policy Board has stayed exactly the same. And so these are some of the questions that I encourage us to kind of percolate on and really delve into at our retreat. John, go ahead.
Yeah, just again, historically, even there was kind of the equivalent of the Oregon Health Policy Board in the John Kitzhaber days, and that model was, you know, Governor Kitzhaber focused on that body as the body that he spoke through in terms of implementing policy and health policy and prioritizing health policy. And I think Governor Brown did the same thing. I mean, I would ask those of us who've been here a while, you know, she did consistently provide, here are the things I want you to focus on. And I find that to be a good model, and I appreciate the legislature and those who are active in it have the ability and should input their sense of things. But I think we're in the executive branch, and my hope is the Oregon Health Policy Board will continue to be a place where the governor of Oregon can come and say, here's my top priorities. I'd like your help and your advice. You have my support, etc. In that. And I think that's the best way to do this.
Great. Thank you, John. Appreciate you sharing your thoughts. Well, happy to have more discussion or any questions about this presentation and the kind of themes it lifted up now or later. And I do want to, before we kind of close on this topic, if there aren't any other comments, do want to highlight that, Tara, I do think that this is something that needs to be a significant, or not as significant, it needs to be a topic at the retreat. So would request your help in making sure that we see that through. Great, thanks. And then I do want to highlight that although some of the questions were kind of challenging or pointed, the hearing did close with Senator Patterson making some very heartfelt remarks about gratitude to the 200 plus citizens of Oregon who volunteer their immense time and energy in kind of serving this bigger effort. And I know everyone on this call today, and as well as all those on the committees, put a lot of time and energy into reading those materials and bringing your life experience and knowledge and kind of thoughtful reflection to this table and the tables of all the committees. So I just wanted to pass along that gratitude because I think it's important to acknowledge in this effort. Thank you. All right. Well, then let's jump back up in the agenda and hope that Julian and Vivian have joined us. And yes, they have. It's great. Well, welcome and good morning. Thank you for tuning in. Well, I guess now we're not early anymore, but thank you for being flexible with your time, Vivian and Jillian. Appreciate you being here. Jillian Johnson is from the Oregon Department of Human Services, manager of the Oregon Eligibility Partnership, and Vivian Levy, OHA's Director of Eligibility Policy Business. So Jillian and Vivian are going to share the updates and progress on redetermination efforts by ODHS, OHA, and our community partners. And take it away whenever you're ready.
Hi, thank you all very much for having me. I'm going to be presenting some material today on what has already happened with redeterminations and what's going to be happening. And Jillian and I are going to operate as a team on this, so she may have to leave early and I'll jump right into her section if that happens. So Tara, are you bringing up the PowerPoint? Thank you. Thank you. All right, so I am here yet again to talk to you all about the unwinding and where we are. Next slide, please. Somehow it's May. I'm not sure how that happened, but here we are. So we're going to be talking about, give you a quick operations update and talk about the timeline overall. Then we'll be talking about the dashboard, the publicly available dashboards and what information is out there right now. And if we have time, we'll talk about some additional resources. Next slide, please. Next slide, actually. All right, so as you all know, February and March were really focused on preparing for the unwinding and doing everything that we could to make sure that people were armed with talking points, information, processes to be able to be successful in starting this. So we really focused on training
making sure that we had already made a lot of updates to the eligibility system, really focused on testing those and making sure that they were working as we expected them to. And of course, continued an ongoing outreach and engagement with all of our various internal and external stakeholders so that they know what's going on. We have implemented a change in the one system that we're excited about that allows us to send out text reminders to people in a much more customized way than we've ever been able to do before. So we're really hopeful that that's going to be an important tool to help people who are busy and have lots of stuff going on in their lives remember when different deadlines have come up, when they have appointments scheduled, those types of things. And we are also, we've just completed actually the implementation of some new functionality around returned mail, so that when mail is returned, we have the ability to use the phone number or email address that was provided to attempt to contact the person in a different way and get their updated contact information so that they don't lose coverage. Next slide, please. So there's three kind of primary outreach methods that are being used to cast as wide a net as possible and also be as focused as possible. So what that looks like when you kind of combine it all together is direct outreach, which is exactly what it sounds like. State staff or community partners actually taking action to reach out to people and let them know what they need to do. A great example of this is that for folks who are in long-term care, case managers are actually directly reaching out to them or their authorized representatives, in addition to all the other communication that's happening to make sure that they have the support that they need. We're also doing indirect outreach, which is what people think of as marketing campaigns, putting information out there in a variety of different ways so that there's broad understanding that we need you to update your contact information if you have Oregon Health Plan. Here's all sorts of tools and places that you can go to get information to understand what is happening. And then there's our partner outreach, which is taking advantage of this unbelievable network that we have here in Oregon of providers and CCOs and community organizations to make sure that we are, again, getting consistent messaging out so that they can be consistent and clear with the people that they are assisting, and also so that they can be the canaries in the coal mine who are able to reach out to us and contact us sometimes more easily than members can to let us know what issues they're seeing so that we can be responsive to them. Next slide, please. So in April, which is, as I said, somehow over already, we conducted the very first, we started, I should say, the very first cycle of renewals. And so what that looked like is we initiate this big process in the one system to attempt to passively renew as many people as we possibly can. And then for those that we can't possibly renew, we send what we call the active renewal packet to get more information from them. This is also the time when we request verification information from people where it's needed. So you can see about 75,000 of the cases that we processed were passively renewed, and 140,000 individuals had their renewals completed in April so far. There were about 46,894 cases with requests for information. You are probably wondering how that measures up with what we were expecting. I would say that it is probably about 10% more than what we were hoping for. We were not sure what to expect. But one of the great things that we have been able to do is dive into this first renewal cycle, have our analysts look at cases and identify if there are requests for information that are getting generated that we don't need to generate. So we're hoping that over the first couple of months, we're going to be able to continuously make improvements so that that number goes down and we're really targeting those where they need to be targeted. About 6,000 cases were notified that they will have their benefits terminated on June 30th because of the information that already existed on their case that indicated that they were not eligible. And that is right in sync with what we were expecting in terms of percentages of folks who would get terminated in this first cycle. So that's a good sign that it's on par with what we expected. You can see that information about the service center wait times. Average wait time was 9 minutes. Maximum for all caller queues was 148 minutes. Average time for the support queue was 1 minute, and for the eligibility queue was 14 minutes. So that's an area of constant improvement, but those average times are staying relatively under control during this first month.
Vivian, would you mind if I chimed in just super quick?
I would love it, please.
So around the wait times, over 2 hours is not acceptable for anyone, even one person. And when we looked this up, this specific individual, our time captures include folks that opt to have a call back. And so this person was not on the phone waiting that entire time. They were waiting to engage with us that entire time, right? But they were not on the phone. They requested and received a callback option. So I wanted to share that information.
Thank you so much for that. I was wondering about that too. And so thank you so much for that.
Of course. Thank you, Vivian.
All right. Oh, just one other thing that I wanted to point out on this slide is that on April 9th, right on time, our marketplace folks did receive that first report, and they have started their outreach processes. The marketplace call center is up and running. So we're very excited that that marketplace transition work, which is intended to help people successfully transition into a marketplace plan if that's what they're eligible for, is in place now. Next slide, please. All right, what's next? So individuals have started submitting the information that has been requested from them. When that comes into the one system, it comes in as a task that needs to be reviewed and worked by eligibility staff. Folks have started responding to active renewal notices. They can do that both in applicant portal, by phone, in writing, a variety of different ways. I already mentioned that the earliest folks will close is June 30th, and we expect that the closer we get to that date, the more individuals may contact us to try to understand what's going on or potentially to provide additional information. We will be starting the next group, the next renewal cycle in this week. And the applications and processes and periodic reviews are, of course, continuing throughout this period of time for individuals who are experiencing the unwinding from a medical perspective. Next slide, please. All right, I'm going to talk about the timeline. There's a number of slides here. I'm not going to go into all of them in detail because we've talked about this before. If you'll go to the next slide. I really would just like to point out a couple of key things here. And then obviously, if you all have any questions afterwards, happy to answer those. So the primary thing that I wanted to talk about here that we haven't talked about in much detail before is the temporary, the interaction with the temporary Medicaid program that has been put in place. You all are familiar with the fact that we're going to be doing these renewal cycles for 14 months. We're going to initiate renewals for 10 months. As we are finding people eligible, one of the things that we are considering them for is the temporary Medicaid expansion. People will start moving into that program, which is for people between 139 and 200% of the federal poverty level. The first time they'll move into that is July 1st. So people are going to be found eligible, actually starting last month, and they'll remain in the program that they're in right now with their current benefits until July 1st, which is the first opportunity for them to move over into that new program. And then they will remain in that program until the basic health program is implemented in 2024. So that is the reason why we call it the bridge, is because the point of this temporary Medicaid expansion is to hold those people, keep them eligible until the basic health program is available for them. So happy to take any questions about that, but just kind of wanted to bring those two timelines together and those two concepts together here, in case you all would like more information about that or do have any questions. Let's go to the next slide.
Vivian, do you want those questions now or at the end?
I would be happy to take them now, or we can take them at the end. I am fine either way.
Okay, I'll throw it out there now, but whatever your pleasure. So just to be clear, from the individual's perspective, they're moved, let's say July 1st, to the Bridge Medicaid program. What do they experience? Even though I see that the funding on the back end will change and now they're on the bridge plan, what do they experience?
Great question. Thank you for that. So the answer to that depends on whether or not they are currently receiving long-term services and supports. If they are not currently receiving long-term services and supports, they're receiving OHP plus, there's really nothing that they will experience. They will not be moved out of their CCO. Their benefits will not change. Everything is really going to be seamless for them. They will just receive a notice that says, effective July 1st, you're eligible for this new program. For people who are receiving long-term services and supports, because that is not offered through the basic health program, if basic health program became the only thing someone was eligible for because they're not eligible for those long-term services and supports anymore at the end of the unwinding, then that would be considered a reduction for them. And they would receive a notice letting them know that they were being reduced from the OHP plus with long-term services and supports to the basic health program. We do not expect that to happen in any sort of large number because of the way that the programs are structured. Most people will just continue in an APD program, but just wanted to call out that that's really the only difference.
And that reduction happens when the BHP comes online in 2024, or does that reduction happen the moment that the person goes to the Bridge Medicaid program?
Happens when they go to the Bridge Medicaid program, because the Bridge Medicaid program does not include LTSS. Of course. All right, I'm going to skip this slide because we've already discussed this one in detail and I want to be able to get to Jillian's updates. Next slide, please. And same with this one. I think we have already talked about this in great detail.
We are running okay on time. So Vivian, if there's something that you
Okay.
want to highlight, or board members, if there's anything in these slides that you would really like Vivian to speak to or have a question about,
Absolutely.
we can afford it.
I think the primary things here are that we will be sending our first reminder notices. And those will go out next month to anybody who has not responded after that first 30 days, because it's confusing, right? We start the renewal process at the beginning of April, but for the members, it's really starting right now for many of them. This is when they're actually going to receive their notice in the mail. This is the beginning of their 90-day period, essentially. I talked about the returned mail process and the text messaging ability. And then this is the only other thing that I will touch on along with that reminder notice. We will be sending out this non-response outreach report to the folks who are listed here with their with their members or the people that they work with, so that they can do more targeted outreach. So we're doing as many things as we can think of at as many different levels to make sure that we don't lose people who remain eligible through this process. Next slide, please. All right, and this is just a kind of a visual overview of this process that we're in. And of course, we're just about to jump into the second line here that starts in May. And as I said, trying to learn from every cycle and make improvements for every cycle. Next slide, please. All right, now I'm going to turn it over to Jillian, and when she's done, we are happy to take whatever questions the group has.
Thank you so much, Vivian. Tara put in the chat the live link to these dashboards that I'm going to talk about. Also, my big apologies, but I have a conflict at 11 that I will have to leave for. So I will, luckily I have a partner in Vivian that will leave you in very capable hands. But if there's anything that Vivian, you feel like I should speak to, I'm happy to follow up. So we can go to the next slide. Basically, there are 2 new dashboards accessible through one link that were launched in April of 2023. And basically, the purpose of these is to show our state's progress in the redetermination process, as well as trying to capture whatever data we can around the people's experience when they're calling our One Customer Service Center and they're looking for assistance with not just medical, but cash, childcare, and food benefits as well. So the next 2 slides are screenshots. So we'll go to the next slide. When you go to that link, the first dashboard you see is the medical redeterminations dashboard. This is actually a screenshot from last week. So the data is different now because more work is being done. So when you go, you'll say, 33,000 initiated. No, it's over 200,000 right now. We are in the process of updating the medical dashboard, and this part is they're validating and designing all the things. So future iterations, there will be a couple more phases. It's very, very simple right now. A lot of that's because, we're 1 month in. There's not a lot to report out on yet. What are happening to people that close? We don't know yet, right? We don't have this amount of data. And so future iterations, like we have, I believe, come and shown just a little information about before. It'll include county level information, demographic information. It will show us what renewals are waiting on information, or are they waiting on action from our state staff, from our ODHS staff to determine eligibility, or are they waiting on response and engagement from the member? It'll break down and show Oregon health plan and Medicare savings programs, so we can see those different impacts. It'll show information around folks going to the marketplace, who's CCO enrolled, who's fee-for-service enrolled, like those are all intended to be shown there. And so the intent when finalized is to really show a statewide view that you can hone down into county level information to gain a picture of what's happening with redeterminations and how we are supporting the people in Oregon and where there are disparities. The next slide really speaks to more of the production and timeliness information. And so this is also work in progress, but what it shows currently is data on call volume, wait times, and customer service survey scores. This information is updated daily. And the One Customer Service Center, when an individual calls, there are different queues, phone queues that they end up being directed to based on their choices. And so, like Vivian showed earlier, the support call queue is about a minute or so wait time. The eligibility queue is about 9 minutes. Everyone together, or the eligibility queue is about 14 minutes, I believe. Everybody together, average overall is 9. So this sort of shows trends. This specific screenshot shows just since April 1st, so just since redetermination started, but you can look back through the beginning of, I think it's the beginning of time, the beginning of one. One thing to note, though, is that the 3-question customer service survey that was implemented in November of this year. And we're moving to a new phone vendor in the coming months that will expand our capabilities for really capturing data and engaging with people. And so we're looking at ways to not just capture these 3 questions, but capture additional information should people choose to. So hopefully more to come in terms of quantitative customer experience data. And that's my time. My goodness. Lovely to see your faces. I will hand it back to my partner, Vivian, who can address questions and then talk about additional resources. I hope you have a good day.
Thanks, Jillian. All right, I will do my best impression of Jillian. Can we go to the next slide, please? I promise I won't do an impression. I'm very bad at those, actually. I'll just try to fill her shoes. All right, let's talk about resources and tools. Next slide, please. So there's a lot of different great partner resources out there that are getting updated on a regular basis, and just wanted to make sure that you're aware of all of these, that you know that you have the opportunity, if you're interested at all, to join the Unwinding Partner webinars. We've got one coming up in English and one coming up in Spanish this month. I really like to join those. I think that it's a great opportunity to hear what partners are experiencing and what questions they have. There's also the newsletter as well as our partner webpage. Next slide, please. So these change tools, which I personally think are really cool, provide a little bit more of kind of an interactive experience with the intention of being member focused and helping people understand what their experience is going to be in the various different scenarios. So there's a change tool that talks about kind of what the member experience is for people who have OHP and long-term care, as well as 3 tools that are specific to people in these various different SNAP situations and how things are changing for them during the unwinding. So I think these are great tools to use when you're either yourself or working with somebody who's truly trying to understand, okay, I get the big picture, but if I'm in this situation, which is complicated, what does this actually look like for me? Next slide, please. This is just some very timely and important information that we wanted to share as people are going through great inflation in food prices at the same time that they're losing greatly needed food benefits. This is a great resource that has been put together to give people places that they can go to get food, to get help getting food. And it also just has the 2-in-1 information if they need broader resources. This is something that is out there and would encourage you to look to and to share with folks that you work with. Next slide, please. And then last but not least, a reminder that we have a feedback email address that goes to an actual real feedback team who is working every day to review the comments and questions that come in, be responsive to those, do follow-up research to be able to respond to those, and also shares that information with us. We have something called Unwinding Command Center, which we do twice a week, and part of that meeting is a report out from this feedback team about questions or issues or concerns or trends that they are seeing. So this is a great and fast way to get us information about either good things or things that could use improvement related to the unwinding process. And with that, just would love to see if you have any questions or comments.
Questions or comments from board members? Before Brenda.
Just waited just long enough, Kirsten, for me. Yeah. I think what I'm struck by, just a comment, I'm just struck by how far we've come. You know, I'm thinking about the level of frenetic energy or panic around this conversation many months ago, and just want to, you know, appreciate the level of intentionality that's gone into the planning work for it. And knowing that, you know, I'm feeling more confident. I also know that the you know, train can go off the rails, you know, with a moment's notice. So I know we're all eagerly anticipating a smooth rollout to the best of our ability. My remaining question, I suppose, is about staffing levels and the ability to continuously manage the wait times, and just any other updates on ensuring we've got the right number of people doing the body of work. You mentioned it already. I just wonder if you can reinforce it. Yeah.
Unfortunately, I wish that Jillian were here to be able to speak to that, but here's what I can say from the work that OHA and ODHS have been doing together. One of the things that we have started working on is trying to take all of this amazing data that we have around the renewal process and what we have been doing before and what we're doing now, and create some meaningful projections. You know, for example, we're going to start getting tons of responses to requests for information. If we know, and I'm completely making these numbers up, if we know that the average eligibility worker can go through 10 of those responses in an hour, and we expect the number of those responses to increase by 20,000 in a couple of months, what does that mean for staffing levels? That doesn't mean that we have the staff or that we have the answers to how to remediate those resource issues, but I'm hoping that it's going to get us a step closer, at the same time that there's a contractor who's working on sort of figuring out what the right level of staff is. And I'm hoping that we can use this in the more immediate future to say, what does this mean that we can expect our backlog to look like in the fall, for example, and get ahead of that and do some mitigation of that up front. So that's what we're working on right now.
Great, thank you. I also think that the dashboards are fascinating, and actually adding on the dashboards are great. Look forward to watching them evolve, especially because you can look over time, and it'll be interesting in future updates and conversations, Vivian, to have that kind of layer on of like, not only like these are the trend lines that we're seeing in the dashboard, but like that doesn't reflect what the demand is. Like that is the wait time, but not the number of calls coming in. And so would just look forward in future meetings to hear your reflection on like putting those numbers into context with the demands on the lines. Thrilled to see, again, people waiting on the phone or not waiting on the phone, getting callbacks. Like there are some critical improvements that so great to see in place. And it's early in so many cycles more to go, but I did love that you highlighted that you're asking questions about what are we learning from this cycle that we're going to apply to the next one, and how do we become more efficient as we go. And so it would also be great to hear some of those reflections as they develop. I have some more, but I'll turn it to Dave.
Yeah, thanks, Kirsten. Maybe just a couple of points from my vantage point. Points from my vantage point. I use point too much there. So just, yeah, I mean, I think the plan for this and the planful nature that the team put together, I think you're seeing that in sort of what's happening. So just thanks to Vivian and a whole bunch of folks between ODHS and OHA for really working hard to get this to be this. And yeah, I think like Brenda, I'm in this like, it's still hard not to get sort of worried about sort of what's in front of us. And, you know, like, I think the whole times will get worse. I mean, it's going to happen. We're We just did a month. We're going to have another month and another month. All of those are going to compound a little bit, right? So, you know, I think we're starting in a spot that, you know, we've got the tools and pieces out there. I just, the piece I would just encourage and happy to think about, are we touching all of the right spots, from community-based organization to navigators and other pieces of just, you know, we've been working really closely with CCOs who have a set of community partners, of just trying to keep everybody sort of going in the same direction. And if you all hear, or if there's like, hey, I'm not sure what's going on. I don't know, Vivian, if there's any other pieces that you wanted to add on any of the community sort of partnering groups that we've been doing, or I know that there's been some, you know, some work and trying to do there. Just to put you back on the spot. I know you love when I do.
Yeah, no problem. I think a couple things that I would highlight. You know, I think our community partners are acting as active participants in helping us to know where outreach needs to be targeted. And we're, you know, we're contracted with the Metropolitan Group to work on this, what we call the indirect outreach. And they have been doing a lot of interactive communication sessions, essentially, with our community partner organizations, so that it's not the state internal team feeding them how we think that, you know, our perspective. It's also a full community perspective that's coming into that. The other thing that I would highlight is, of course, other things are happening during this unwinding, and one of those other things is expansion of the Healthier Oregon program, which is scheduled to happen in July. And so one of the lessons learned from Cover All Kids, and then from the expansion to Healthier Oregon, that we're also trying to apply here, is working. We know that a huge percentage of the folks both on COWAM and on Healthier Oregon are working directly with a community partner. And so that's an area where we are directly engaging with those community partners who are contracted to do that specific targeted work, so that they can be making outreach calls and doing direct outreach to that population, because it's going to be confusing what's happening, and we want to have them talk to a real person on the other line who can help them through that confusion and help demystify the process. I see Dr. Santa's hand.
Oh, sorry, I did not unmute myself when I said, John, go ahead.
Yeah, thanks. As I listen, I just wanted to ask Vivian, so what do you do with people who have a proxy? So a proxy calls and says, I'm trying to help this person, and they've gotten this notice, and you know, they're not capable of figuring out what's going on. So how do you all deal with proxies, if at all, if you can?
Yeah, thank you for that question. We have three options for doing that. So the first one is somebody can assign an authorized representative to act on their behalf. And then we will interact with that authorized representative just as we would if they were the member. They can do everything for the member on their behalf. That's kind of the most official level that we have. And that requires a form to be signed by the authorized representative and the member, acknowledging that relationship. The second level under that is a authorized to talk with a third party form that we have. And that just requires a person on the phone to say, you know, hi, I'm here with my uncle and I need them to talk to you. I can't talk to you right now. Will you talk to them on my behalf? And then that call can be handed off based on that verbal authorization, and the eligibility staff can talk to that person on their behalf. And then there's a third layer, which CMS has, we've been working with CMS to implement over the last couple of years, which is that for a person who is incapacitated or under the age of 19, a person can act on their behalf in a much less formal way by submitting an application for them, and even helping them renew their coverage. So that's a process that is most frequently used either with unaccompanied kids or with our APD population. But so we've got those 3 layers in place that allow us to work with somebody other than the member.
Great, thanks.
Of course.
All right. Vivian, there's one, I was very interested in seeing the change tools, and I think in the PowerPoint, it has access these tools here. That link is going to a broken OHA page for me.
We will get you all the correct link.
Great, thank you.
You know that.
And then I did want to highlight that, you know, we've been talking about these redetermination renewals for a long time. And so when I started to see from my kids' schools' weekly newsletters, reading about how to engage in OHP renewals and the redetermination process that was coming, I was so thrilled. And so just something out there's working. I read about it every week from a different source.
Music to my ears. Thank you.
Okay.
Thank you all
Any
for
other?
having us.
Say that again. Sorry.
Oh, I was just saying thank you all for having us. But yes, of course, any last questions, happy to address.
All right. Well, thank you, Vivian. Please pass along our gratitude to Jillian as well. Thank you for being here and the work of that large team. Okay, so next up is public comment. We do have someone signed up for public testimony today, which is great. Folks have a few short moments now. If you are interested in giving public testimony, please connect with Tara in the Zoom chat. The Oregon Health Policy Board welcomes and deeply appreciates public testimony. It's one of the most powerful ways we demonstrate our commitment to profound listening and learning. And deep listening means that we will not respond to what you share, nor will we attempt to fix or resolve the question or concern that you bring today. We will not interject or correct inaccurate comments that are shared as fact. We will, however, bring it fully into our awareness, understand it as an important consideration for our work, and listen with careful attention, respect, and honor that you deserve. We want to acknowledge that time held in our meetings to hear public testimony is meant to provide a voice and perspective from that individual, and it's not representation of the Oregon Health Policy Board, its members, or the Oregon Health Authority. Each presenter is given 2 minutes to share. And in the event that that doesn't feel like enough time, we encourage you to provide written testimony, which we commit to reading. And to keep us on time, we'll start a 2-minute timer for each commenter. We kindly ask that commenters conclude their presentation when the timer is complete. Know that written and verbal public comments will be reviewed and discussed following each meeting by the board chairs and staff to determine the appropriate next steps. And board staff will communicate those next steps with each public commenter. So I would like to welcome Mike Huntington. You're welcome to turn your camera on while you give testimony. Is Mike with us?
Yes, can you hear me?
Yes, I hear you wonderfully. Great. Proceed whenever you're ready, Mr. Huntington.
Okay, I'm trying to turn on my video, but that may not work. So I'm Michael Huntington from Corvallis, a retired physician in several leadership positions from healthcare advocacy groups in Oregon. You are all doing a tremendous work to provide better care for more people at lower cost. Thank you. Each of you carries, however, an extra 50 pounds that an invisible hand has placed into your backpack. You can remove about half of that extra load by eliminating the marketplace concept. Competition in the marketplace is good, except in healthcare. Competition means avoiding clients who might be costly. Competition means doing everything possible to maximize reimbursement. Competition too often means denying needed care. You are working hard to help those who can't afford the market, but that always means creating a fiscal cliff. One year I make less than $22,000 and I qualify for Medicaid. The following year I earn a few dollars too much, losing my doctors and any sense of healthcare security. My two requests are: remove the marketplace from your lexicon, remove fiscal cliffs from your planning, support Oregon's current legislation to create a proper unified payer healthcare system that will reduce administrative overhead by half, lighten up your backpack, and provide better care for more people at lower cost. Senate Bill 1089 is a critical step forward. Senate Bill 1089 establishes a governance board to create unified payer legislation. The legislation incorporates the recommendations of the Senate Bill 770 task force. Senate Bill 1089 passed out of the Senate Committee on Healthcare with a 5-0 bipartisan vote. Last week, the Senate Rules Committee passed the bill with a bipartisan 4-1 vote. The committee recommended passage by the legislature. Lighten your load, reach the summit, support Senate Bill 1089. And thank you again for your work.
Thank you so much for joining us here today, and I like the analogy. Great. Well, thank you. Tara, do we have any other public comment requests?
That is the only one we have received.
Okay. Well, then we will move to our wrap up. Some of our takeaways for today. Tara, help me out, make sure I've captured all of them. There was a request to hear from the healthcare market oversight at a future meeting. Share the reports from the READ group, which I think you already did in the chat. To just see if there's any data on long COVID specific to Oregon.
Yes, email already sent to Dean Seidlinger.
And that's where my notes stop. What did I miss?
Okay. I'm gonna also see if we can find some information on low vaccination rates and the communication campaigns there. We will hear an update at the June board meeting, if not sooner, on the OHA director recruitment process. We will also, there was one more item. Actually, I think that was it. If there's anything else that we missed, people could speak up or let me know, but we will follow up on those items before the next meeting.
I just had one piece of follow-up around the retreat agenda and support that you, Kirsten, and Oscar, Tara may need from us around setting that. So if you need anything from us, don't hesitate to reach out. Yeah.
Great. Thank you so much for that offer, Brenda. Tara, do you want to add anything about the retreat?
Yes, we were going to have a conversation at our weekly planning meeting next week on Tuesday, the 9th. Members are welcome to join. That is just an informal conversation. No business or decisions will be made. So if members do have capacity and interest to participate, we would love that. And also thank you for participating in the initial doodle poll for your availability. Since we could not find a date that worked for all members, we are going to cast a wider net, and so you'll be receiving a doodle poll with nearly all days in by August and September and into October, so that we can find the best fit for us all to be together in person.
Great. We'll keep an eye out for that doodle poll and fill it out. Thank you, Tara. Hopefully we can find a date where all of us can join in person. I think it'd be important to have all the voices there. So I do want to remind the board that the cost growth target public meeting is May 17th. And those two reports will both be out by next Tuesday, May 9th. Keep an eye out for those. And if you are able, please tune into the hearing on the 17th, if not participate in it.
What time is it at?
It's in the morning. I think it's, Bill, do you know what time it starts? 9:30, 10, something in there. But yeah, so it's in the morning, first half of the day, virtual. And Tara, I would love to request that you send out an invite to us.
It's 9 a.m. to noon, and I'll drop the link to the page here in the chat, and then I can also forward members this information so they can get the Zoom meeting on their calendars.
Great. Thank you, everyone. Our next Health Policy Board monthly meeting will be Tuesday, June 6th at 8:30 in the morning until noon. And with that, I hope you all have a wonderful week. Thank you for your participation today. Bye-bye.